Welcome to Marrow Masters, sponsored by the National Bone Marrow Transplant Link, Seattle Genetics, and our esteemed link partners. The National Bone Marrow Transplant Link, established in 1992, strives to help patients, caregivers, and families cope with the psychosocial challenges of bone marrow stem cell transplant from diagnosis through survivorship. This season will focus on busting marrow myths. There are many myths related to transplant. Am I too old for a transplant? Are clinical trials exploratory and dangerous? My chronic GVHD will never end. Or will it? Does palliative care mean hospice? Is our love enough to get us through this cancer? No match in my family. Am I out of options? And timely info on CAR T cellular therapy as it relates to transplant as another option. Here's the host of Marrow Masters, the Executive Director of the National Bone Marrow Transplant Link, Peggy Burkhardt.
At this time, I'd like to welcome Shirley Otis-Green. Shirley is a palliative and oncology social worker. Shirley's education, research, and consultation efforts have led her to become an internationally recognized speaker on quality of life, palliative care, and transformational leadership. Shirley is the founder and a consultant at Collaborative Caring in Toluca Lake, California. Shirley, it's time to bust another myth.
That's great. Thank you so much for the opportunity to talk with you today.
We so often hear the words palliative care. Should someone be afraid? What does it mean? How does palliative care differ from hospice?
Great questions. We'll tackle them one at a time if that's okay. So palliative care is the best thing since sliced bread. I know a lot of people hear those words and are not sure even what it means. Palliative care is a relatively new field, but it's not at all a new concept. Let me think of how best to explain it. If we think of most of the treatments that a person gets, we think of it in terms of trying to address the disease directly. So chemotherapy is trying to shrink the tumor, or radiation trying to shrink a tumor, surgery trying to take the tumor away. But palliative care is for all of the quality of life concerns that go along with either the illness or the treatment. So palliative care is trying to improve function, improve quality of life, and look at a person holistically. Palliative care professionals, the people who specialize in palliative care, have special training so that they can ensure that a person's symptoms or the stress of a serious illness are addressed and managed in the very best way possible. So all of the efforts that go into helping a person to feel better are under the category of palliative care. We hope that a regular primary oncologist or primary hematologist or primary care provider has what we might call primary palliative care expertise. We hope all of them know how to manage the common side effects and symptoms of an illness that they might be treating, and that they know and have access to their colleagues who might be considered palliative care specialists who can help if the illness is more advanced or if the concerns are more complex. Does that help clarify that a bit?
Oh, it sure does, Shirley. Thank you.
So when a person hears that a doctor is thinking that palliative care might be useful, we don't want a person to be frightened. We want them to be excited that their doctor is looking after their quality of life needs as well. So for example, there have been lots of research and studies that have been done that demonstrate that people actually do much better when there's an early referral to palliative care and a simultaneous palliative care treatment plan. So a person, for example, who has a diagnosis of a serious illness of any kind, so again, a cancer diagnosis certainly fits that characteristic. A person with a serious illness diagnosis, such as cancer, is likely to do much better if they have an earlier palliative care consultation, having a chance to meet with the palliative care providers and have them simultaneously follow that person as they get their treatment over time. The palliative care team, and I focus on the word team there, palliative care teams consist of people who have expertise, who are physicians, nurses, social workers, chaplains, and others who can address the multidimensional aspects of illness. And by that, I mean focusing on the physical, psychological, social, and spiritual concerns that accompany a serious illness.
That's so true. I love the team approach. Is that becoming more and more popular?
It certainly is. Palliative care has, as part of its definition, an interprofessional focus. It always is a team approach. So if someone says to you that their hospital or their clinic, has a palliative care service and they don't have an interprofessional team, then they don't really have a palliative care service. It's inherent in what palliative care is all about, a collaborative team approach. And we know that that's a key to helping the person to do better, because illness isn't just a tumor in a body. It's really, it affects the whole person. That's part of the challenge of cancer, is it's systemic. It affects all of the body parts, but it also affects who you are, and can affect your family, and can affect your finances, and can affect your sexual functioning and your spiritual and existential concerns that might arise because of the illness and what it represents. So having that team approach is really a critical factor in the effectiveness of a palliative care consultation.
I think this is great. It really clears up the palliative care definition and what it means. How would you address the role that spirituality plays in all of this?
Sure. I think one of the things that's so powerful about the palliative care approach is that it recognizes that there are spiritual or existential or perhaps religious ramifications to having a serious illness. For many people, when they hear the word cancer, there's an invitation to consider the possibility of one's own mortality. We all know that at some point people can die, and in fact that all people will eventually die. But most of us go through our life thinking of that as kind of an abstract. That happens so many decades in the future, or it happens to other people. And so even though intellectually we know that that's going to be part of our fate, the diagnosis of a serious illness like cancer can make us suddenly feel all of the existential concerns that go with recognizing that we might die, that it might be me or someone in my family, someone I love and care about. That person might die. And those things are associated with existential, spiritual, and religious implications. We think about what's our meaning and purpose in life. Does anything I do matter? If I've got cancer, maybe, I should give up and roll over. And we know that people do better when they can still identify ways to make meaning and to see that their life is still very precious, no matter what the outcome of the illness. And so helping a person to feel grounded in their sense of meaning and purpose is a big part of what the palliative care team can try and offer to support a person as they're making sense of their illness and incorporating that into their daily life. So although I mentioned that palliative care is a system of providing support for a person with a serious illness, it is often associated with people who are facing end of life. So sometimes you'll hear palliative care and hospice as linked terms. And in your opening question, you asked about the distinction between those two. If I think of palliative care as the larger umbrella of services, hospice is definitely a part of palliative care. We want all of our hospice providers to be palliative care experts. We want them to know about symptom management, how to help a person to feel better, how to improve their function and improve their quality of life, no matter how serious their illness might be. So people who are getting hospice are people who are facing the end of their life, that there is no more treatment options that are likely to change the outcome of their illness. And palliative care content, palliative care expertise, is part of what's provided for people at end of life so that they can do as well as possible. Hospice providers also attend to a person's psychological, social, spiritual, and physical concerns. And hospice also has chaplaincy support. We hope that a person who has a serious illness has an opportunity to access hospice earlier rather than later in their illness trajectory so that they can get the maximum benefit from those supportive services. Many people who get a referral to hospice will say, I wish I'd have known about this sooner, and they'll find that their loved one actually often does quite a bit better when they have that full attention of the team. So being able to access palliative care earlier is better, and being able to access hospice if the treatment options are no longer working is also related to better outcomes. People doing better and people having better quality of life, and often, again, living longer than comparable groups that don't have access to palliative care or hospice.
Are there any resources that you highly recommend, perhaps a book or a documentary, anything that you could think of that would really help someone that might want to watch more about this?
Sure. The good news is that there is now a plethora of wonderful options and wonderful resources. One of my favorite recommendations, is Dr. Google. And if we were to check the internet, we would find that there's organizations that are devoted toward helping people to understand palliative care better and helping understand programs such as hospice better. So if a person does have a diagnosis of a serious illness, being able to learn about those tools and resources earlier on, again, is associated with better outcomes. So being able to ask for a palliative care referral, ask for the opportunity to talk to a palliative care team is a good strategy. And if you are looking online, there's an organization called CAPC. It's the Center to Advance Palliative Care. And they have resources for the experts, for the providers and clinicians, but also for lay people as well. The National Hospice and Palliative Care Organization similarly has information for the clinicians, but also has information for lay people or patients or family members. Many of the cancer support programs will have information for palliative care. Things like AARP also has palliative care information. So just as a function of as we get older, we might have multiple conditions going on in addition perhaps to cancer, and again has information on palliative care. Being able to read about it, there are lots of resources now. There's a new book that just came out called A Beginner's Guide to the End, which is quite fun and has information again about serious illness, again, perhaps one that has the possibility of life-limiting outcomes. And it is written by physician colleagues who understand palliative care and have really tried to look at many end-of-life concerns in a way that is user-friendly for a patient. It's not written for a clinician. It's written for real people who have real illness. Atul Gawande's book, Being Mortal, came out just a couple of years ago, but is really a wonderful resource. Again, something that I would recommend that helps us understand about palliative care a little bit better. And Ira Byock, another physician colleague, has a book called The Best Care Possible. And I really love that. It's a physician's quest to transform care through the end of life. And it too has lots of great information for a lay audience as well. Many of the books that are written for clinicians can be quite useful for a person to read on their own. The American Cancer Society has a book called When the Focus is on Care, and it looks at palliative care and cancer. That's a few years old now, but the principles are still very valid and again would still be helpful. Jimmy Holland has a book called The Human Side of Cancer. What you might notice as I talk to you about these resources is what they have in common is not so much focusing on the treatment, but it's focused on the impact of that treatment on a person's whole life. So the idea of palliative care is to be holistic, to focus on a whole person and a whole family who's going through the implications of that illness or its treatment. So we know that having chemotherapy, for example, is associated with all kinds of potential side effects that can be uncomfortable. And if our doctor is only focused on trying to shrink the tumor, which is great, that's important to do. We all want to make sure that we have the best outcome physically from that. But if we don't pay attention to the side effects of that treatment, then we know that that person isn't going to be able to tolerate the treatment to be able to get the full benefit of it. So we need to be able to manage the side effects and the possibilities of nausea or vomiting or constipation or physical pain or the anxiety or depression that can accompany the illness so that the person can get the very best response and have the most resilience in being able to tolerate the actual treatments that are trying to be curative or to extend life. So a person shouldn't be worried or anxious that the doctor's thinking about palliative care, but rather thankful that they're being open to looking at how they can get additional support for the person going through a serious illness. In fact, the organization CAPC that I mentioned to you earlier, the Center to Advance Palliative Care, they like to think of palliative care as being described as an extra layer of support. That's really the key part of the definition. It's just an extra layer simultaneous to while you're getting your treatment, but being able to focus on helping you to be as strong as possible and live as well as possible for as long as possible.
I like that. That's a great way to put it. Almost like another blanket.
Right, exactly. In fact, the word palliation comes from the Latin to palliate or to cloak or to cover. So you're absolutely right. That idea of it's a blanket, it's that extra layer of support is inherent in even its name.
Wow, that's so interesting. I did not know that. This is terrific, Shirley. Is there anything else you'd like to convey or add at this time before we wrap things up?
Sure. Since I'm thinking now about the etymology of the words, hospice comes from the same root as hospitality or hospital. All of those words are meant to connotate taking care of someone along a journey. And so if we think of a normal lifespan, again, recognizing that there is the reality that all of us are, by definition of being human, we are all mortal, being able to hear that the doctor is thinking about a referral to hospice hopefully also isn't a terrifying realization, but rather can be seen as a physician who's recognizing that this person's response to a illness is no longer likely to be as favorable as we had originally hoped. So when a physician identifies that the illness is progressing and that there are no longer likely to be treatment opportunities that are going to change that outcome, then being able to explore what can we do to make sure that the person who is now facing a potential end of life gets all of the support and that the family gets all of the support that they possibly can as early as they can so that that person can do as well as they can, again, for as long as they can. Our hope is always that we can extend quality of life for a person indefinitely, and yet we need to recognize that at some point we are all going to be mortal. So being able to see any of these conversations about palliative care or about hospice as something that comes from the physician's desire to ensure that you or your loved one has the very best possible quality of life is actually a beneficial thing. And although it's, of course, touched with sadness, that's again why there's that team approach to help us to manage our emotional and social reactions to this. You know, what can we do to be as well prepared as possible, you know, if our outcomes are not as we had originally hoped. But palliative care, again, is that larger umbrella of services not meant to be limited to the time of end of life. So I do just want to reemphasize that all of our studies and all of the evidence at this point to people doing better the earlier in the time of diagnosis that palliative care can be introduced. So having palliative care thoughts early on is a good sign, not a bad sign.
This is fantastic. Thank you so much, Shirley. I think you've really cleared this up, and we so appreciate your time.
Well, our goal is to bust as many myths as we can.
We're having fun doing this.
That's great.
Thank you very much. Have a great day.
Thank you. My best wishes to all.
This has been the Marrow Masters Podcast. Feel free to share this episode via social media, text, or email. To hear more, subscribe for free to Marrow Masters in your favorite podcast app. To learn more about the resources available to patients and caregivers, check out the National Bone Marrow Transplant link at nbmtlink.org. That's nbmtlink.org, or just tap the link below in the show notes.